All right. So welcome everyone to our talk. Our talk's called Improving Painful ED Experiences Alongside Opiate-Tolerant People. If there are any tech issues throughout, please feel free to chime in the chat and tech's going to help you out. And feel free to type any questions into the chat and we'll do our best to answer them either in the chat or at the end of the presentation. So we'll get started here. Just in terms of the disclosures, an earlier iteration of this program received some honorary support from Choosing Wisely Nova Scotia. It hasn't received any in-kind support at all. Katie has an honorary for lived experience with CAMH. Neither Alex nor I have any commercial interest relationships, although I did want to mention I have a funded PGME residency position through Dalhousie University. We want to begin by acknowledging that we're presenting from Mi'kma'ki, the traditional or ancestral territory of the Mi'kmaq people. We also want to acknowledge the disproportionate harms and risks to Indigenous people from both acute care experiences and the toxic drug crisis that are rooted in colonial and institutional violence. And that young Indigenous people who use drugs are 12.9 times more likely to die than people their same age, other people their same age. So we also want to note, really importantly, the resilience of Indigenous traditions, languages, culture, and spirituality, which contribute to that resilience and resistance amongst Indigenous people who use drugs. And I wanted to extend a thank you to May as well during the keynote for sharing her knowledge and describing how hospitals disown patients from this population and encouraging us in the ED to raise the bar in caring for and managing effective referrals for the population. So I think it's a really important message, and that phrasing of disowning will really stick in my head. So thank you, May. So there's three main objectives of our talk today. We want to first provide a strength-based overview of the risk and burden of pain and ED visits. We also want to talk about the risks of transitions during, before, and after ED experiences for opioid-tolerant people. And then finally, to strengthen communities of care and pain management strategies during these high-risk moments. And so overall, we want to talk about the risks that people face accessing the ED, like our panelists have mentioned this morning, and the excellent care that primary care provides to smooth transition in and out of the hospital. And I also want to extend a thank you to Ashley this morning for sharing her experiences with mistrust and under treatment of pain in the ED and during childbirth. Those are really powerful stories that I think illustrate the real harm and neglect that we can cause in the ED and also illustrate, sadly, how common these experiences and stories are. And so we really, in the ED, need to do better at trusting our patients and providing care alongside them. So my name's Lewis. I'm an emergency medicine resident at Dalhousie University. Prior to working here, I worked as a case manager at the Vancouver Cedar Project, which is an Indigenous-led Hep C study in Vancouver's downtown east side. I'm co-presenting today with Alex Smithers. She's an expert ED pharmacist who is a great champion for this population in our department and helps navigate those risky transitions alongside people accessing ED care on a daily basis. And then most luckily, we are joined by Katie, who I think many of you met this morning during the panel. She has a wealth of expertise from her own lived experience and from working in care development initiatives. So we'll be hearing an intro from her shortly and then sharing some ED experiences in pre-recorded videos throughout the presentation. So, and I really thank you, Katie, for your courage in sharing these stories. Before we hear from Katie, I just wanted to give a quick definition about what opioid-tolerant people means in our talk, or opioid-tolerant people, rather. They're a diverse group. It's not necessarily just people with a DSM-5 opiate use disorder diagnosis. Much of this will apply to people with active substance use disorder or street opioid use, but much is relevant across a wide range of at-risk for undertreated pain opioid-tolerant people, including those on opiate agonist therapy or other prescribed opioids. So why don't we hear from Katie, if you wouldn't mind doing your introduction.
Thank you, Lewis. So as some of you might know from the panel, my name is Katie Upham. I use she, her pronouns, and I live in Mi'kma'ki as well. I am a self-employed harm reduction and substance use health consultant. And as Lewis mentioned, I will be sharing some ED experiences with you. But to begin, I wanted to tell you a bit about my experience with opioid use, just to provide some context and humanize today's discussion. So my use of opiates began in 2009 while working towards completing my Master's of Developmental Economics at Dalhousie University, and I was a classic overachiever. I was a teaching assistant, a registrar's office representative, and research assistant, all while going to school full-time. Achieving academically and staying incredibly busy was how I coped with the trauma I'd experienced in my childhood. At the time, my roommate, who was a pharmacy technician, brought stolen prescription opiates home from work one day, and I had used almost every other drug recreationally up until that point. They never interfered with school or work, so given the opportunity to do the same with opiates, I didn't hesitate. Whether I was using opiates at the time or not, I recognize now that I had an impossible amount of work for any human to do at the level of perfection that I expected of myself and was headed for burnout. Inevitably, my grades slipped, and rather than receive even one subpar final grade on my transcript, I quit my master's. I therefore lost all of my on-campus jobs because I needed to be a student in order to keep those positions. Gone were my coping strategies of academic achievement and workaholism. My identity and purpose for those first 21 years of life had been as a student, and that was what I was praised for and successful at. So having that identity all of a sudden disappear, I was very distraught. I had a suicide attempt shortly thereafter that put me in a coma for 2 days, and I remained in hospital for 3 days for observation and mental health support. I found the mental health treatment I received very unhelpful during my hospital stay, and shortly after discharge, I switched from taking opiates by mouth to injecting them, and that became my new full-time job. It occurs to me now that this hospital stay could have been an opportunity to facilitate the prevention of this escalation in my opiate use to injection. Unfortunately, my experience only aided in increasing my use and was that the catalyst towards switching to a more harmful mode of administration. There was no follow-up or transition in my care back to community upon discharge. I felt more hopeless than before I entered the hospital. I found that opiates were a really effective way to numb my deep sense of failure, anxiety, and traumatic past. Opioid use was a deeply personal ritual for me, and the shame of injection use kept me in isolation, so I found myself using opiates alone every day. Early on, when I was in my darkest days, I believe opiates even saved my life because it protected me from the feelings that I didn't have the capacity to cope with at that time. So over the next 8 years, I struggled to achieve abstinence, but not for lack of trying. I went to 2 long-term treatment facilities, attended inpatient detox more than 25 times, regularly went to 12-step meetings. However, I could not go more than a couple of months at a time without using opiates. I experienced so much judgment and stigma in accessing the very treatment services and recovery programs intended to help me. And I almost died trying to achieve abstinence and refused OAT for years because of the social stigma that's pervasive around it. Just a note about the mental health support that I needed to recover from past trauma. It either cost too much money, was nearly impossible to access, it had these lengthy wait lists, or left me feeling ashamed and discriminated against due to my drug use. So it was difficult to address the root causes of my opiate use, and further trauma was piled on top at the hands of our healthcare system. Finally, in 2017, I was beat down enough by these repeated attempts to achieve abstinence that I was willing to try methadone. I really didn't like how methadone made me feel, and so by 2021, I had tapered off of it. But I also felt I couldn't continue to subject myself to what I felt were carceral and paternalistic policies of the opiate clinic I was attending, like daily witnessed dosing and punitive drug urine tests. I found that traditional addiction medicine programs didn't give me the flexibility or agency that I needed over my own life. I was tired of all the rules, and I felt that I wasn't really trusted by my doctor. I believe since 2021 that some of those restrictions have loosened, and some has changed since then, but these experiences certainly soured me against those treatments and clinics. So I had been completely abstinent from opiates for about 2 years until March of 2023, when again, sort of those perfectionistic and workaholic traits led me to burnout, and I started injecting opiates again. As many or not, I was not ready to stop using right away, but I feared for my life because of the toxic drug supply. I had a relationship with Safer Supply doctors through my work, so I was very privileged to get into a Safer Supply program in Halifax, Nova Scotia. So I was prescribed a lot of tablets for my opiate use that I picked up daily, I took home, and I used however I wanted. For the first time, I was able to be honest with my doctor. They knew I was injecting, and that was okay. They didn't push me to change this behavior. They didn't use guilt or unnecessary restrictions to control my behavior. Having a regulated prescribed supply of drugs, I didn't have to spend enormous amounts of money and time trying to find drugs on the street, and my use was no longer criminalized, which greatly lessened the negative impacts of my return to opiate use. My life remained manageable, my relationship stable. I opened my own business that year and had the most successful financial year of my life, injecting drugs daily. However, without pressure from my doctor, but motivated by my own goals and concern about what injection use was doing to my body, I made a decision to change my relationship with opiates. So after about 9 months, I stopped injecting and I transitioned off of Safer Supply. So along the journey I describe, I've accessed healthcare at the hospital, including admissions through the emergency room many times. I found that doctors did not understand my OAT, or that my Safer Supply was not sufficient to cover my acute pain, and they often denied me pain medication because of my history of opiate use. I was terrified of withdrawal, misunderstood, and often stigmatized. So it's my hope that through this presentation, you may learn how to support opiate-tolerant people with acute pain in a compassionate, stigma-free, and trauma-informed way. Thanks.
Thank you so much, Katie. There's so many opportunities we could have done better along that way. So I want to talk about why pain is such a dangerous problem for this population. So it starts out with the baseline burden of pain. So the prevalence of chronic pain in this population is so high, somewhere between 50 to 60% for people with active substance use, or it's been also studied in people on methadone. That's compared with the general population of a more prevalence of about 10 to 20%. In addition, pain sensitivity is increased due to the effects of hyperalgesia from opioids, which is nociceptive stimulation caused by prolonged exposure, which makes acute pain experiences worse. In addition, people are predisposed to painful conditions, things like infectious disease, violence and trauma, and of course, people with lived experience in substance use are actually very overrepresented in the traumatic injury population that we see in emerge so often. And of course, when people access care, experiences of stigma are so common, and qualitative studies have linked anticipated stigma, mistreatment, and shame in healthcare settings to things like delayed presentations, non-disclosure of substance use, and seeking care elsewhere, as well as high-risk use activities while in hospital, like using alone in locked bathrooms. And of course, stigmatizing provider behaviors like denial of pain medications have also been reported. I wanted to touch on stigma management communication, which is a communication strategy that I think gives a helpful framing for why people might use unexpected communication techniques in the ED, and to manage their own care. So it's things that people do when they're in stigmatizing environment, like misrepresentation, under or overstating their pain, anger, non-disclosure, or downplaying their health needs so that they're perceived as legitimate recipients of care in these stigmatizing environments. And then, of course, past experiences cluster. There are numerous studies that show negative experience of people with substance use or opioid use in care spaces, and not just in the ED, but many in inpatient settings, outpatient settings. But of course, the ED is an important site of access and can be a bit of a gatekeeper. So those past experiences are important and compounded, especially for people from equity-deserving groups who have experienced institutional violence, both historically and currently. These then are shared widely amongst communities. It's beyond just that one person. And conversely, good experiences can spread as well. This, of course, all combines to result in care avoidance for many people. This comes up a lot in the literature, not always just avoiding the ED, but the ED is, again, often the first point of contact for acute painful conditions. There's a ton of fear and a ton of self-managed pathology in the population. And for those of you providing care in the community to this population, I'm sure many of you have seen pathology that ideally should be in the ED or even in the ICU that you're then treating with your adaptive community care as an outpatient. And then finally, all of these combine to put people very significantly at the risk of undertreatment. And there's actually research that suggests that people who use drugs who have concurrent pain may be more likely to be denied pain medications. There was a 2021 retrospective review that showed that people with a substance use history were both less likely to receive opioids, and then if they did, they would receive fewer, which is paradoxical because, of course, opioid-tolerant people need more to manage their pain. And then frustratingly, there's also a significant dose-response relationship between increasing pain severity and greater likelihood of reporting barriers to accessing health services in the population. It's really sad. And then people also report that undertreated pain is a very common reason to leave the ED before medically advised, which of course puts people at high risk of overdose and mortality. We've spoken a lot about of risk and vulnerability, but I think it's really important to highlight the strengths and skills people use to protect themselves and to develop harm reduction strategies in their own lives. Because of course, people provide the vast majority of their own pain management. Our central point of our talk is that people often know what works for them. And as care providers, we're here to assist with our expertise on their journey and trust them as the own experts of their lived unique pain experience. Things people do might be pharmacological and non-pharmacological management, coping strategies, mutual aid for painful experiences with friends and family and peer support, cultural practices, substance use patterns that might also include the seeking of euphoria to offset pain or managing withdrawal and pain. And then, of course, organization like regional and national advocacy from people with lived experiences, like the Canadian Association of People Who Use Drugs and regional substance use unions, who enact a lot of meaningful change. And I think it's also important to note that harm reduction itself has flowed from the work of these communities into healthcare settings against a lot of resistance. So we owe them a big thank you. And then, of course, people, in addition to their baseline burden of pain, they are facing, when they come into the ED, all the burdens that EDs are facing. They have multifactorial strains, things like longer wait times, things like access block and hospital overcapacity, things like staffing shortages, increased patient to provider ratios, and caregiver burnout and empathy fatigue. So a really challenging setting to visit. Some of these barriers that we just wanted to highlight are things like education. So there's when people access the ED, there's a varied level of provider education and familiarity, which can lead to some serious heterogeneity in those provider-patient interactions. People don't know what to expect. And then, of course, there's challenges in ED settings with implementing education in the context of strained ED resources, which limits the spread of good harm reduction oriented care. Then the policy barriers. So there's unwritten and written abstinence-only policies in many healthcare settings. There's prohibitive policies meant to prevent access or use to substances, things like searches, discharges, law enforcement and security involvement, restrictive leave policies that actually may create harm, conflict, and the risk of OD. And a big challenge that we run into this in our setting as well is that unsupportive policy leaves care teams feeling at risk in terms of their licenses to provide adequate management of pain and analgesia. Then, of course, the resources and infrastructure. So there's limited availability of resources in terms of pharmacy, addiction services, social work, peer support, et cetera, depending on the day, the hour, and the site. There are hostile spaces in emergency departments. There's lack of privacy. There's crowded, bright, noisy, stressful, and re-traumatizing environments that might remind people of other institutionalizations that they've faced. And then, of course, the human factors. So things like buy-in, burnout, stigma and empathy fatigue, and stigma and perception of things like drug seeking and sort of drug war, inherited things like that. And then more recently, sadly, also the politicization of in-hospital care, which amplifies all of these challenges. But there is also an increasing recognition that, and as Katie mentioned, that ED visits also represent a key moment of engagement with the healthcare system for this population, and represents a great opportunity to open doors to care and services that people want and might benefit from. So we wanted to move on to a case here. So this is a 39-year-old person with significant burn injuries who presents to their family physician and nurse practitioner in a community health center. They have a history of previously treated endocarditis, including multiple stressful visits to the ED for that, with inpatient stays as well. And then they had 2 non-fatal toxic drug poisonings revived by peers with no paramedic or ED involvement. The person has previously been using street opioids, including fentanyl. That was exclusively before, but is now on prescribed slow-release oral morphine, which they usually take orally but occasionally inject, in addition to supplementing with street fentanyl on occasion. So they visit their trusted family physician and nurse practitioner at the community health center, with whom they have a multi-year relationship, for help. They've been at their apartment since this happened, so they haven't made it to their pharmacy this morning. They show their providers their burn injury, which is to their upper arms, to their chest, and to their abdomen. Their providers recognize this as a serious burn with sufficient skin involvement to need a trip to the ED for IV fluids and ongoing burn management. I'm sure scenarios like this are some of you have encountered, and I just hopefully we can keep this patient in mind while we go through this talk, and we'll be picking up this patient later.
So as Lewis mentioned, throughout this presentation, we also want to take you through a patient's potential journey and transitions of care, from life in the community to the emergency department, and then from admission and departure. In reality, though, it's much more complex than just putting ED in the center of this journey. Transitions in care are cyclical and can look like representations, but also just a snippet in a patient's life and their lived experiences with, as Lewis mentioned, people managing their own pain. So transitions of care are defined as a movement of patients between healthcare locations, different providers, or different levels of care within the same locations, and they're recognized for all patients as high-risk scenarios for patient safety. The patient's journey involves a lot of different interfaces between a lot of different people and a lot of different words that are being presented to them, new treatments, new medications, just to name a few. So transitions of care for all patients constitute a priority focus for the World Health Organization to prevent medications harm. People are vulnerable when they move between parts of the healthcare systems. There's increased mortality, increased morbidity, and increased adverse effects. Emotional and physical pain and suffering from service users and carers, families, and clients occur during these transitions of care. And what matters most to patients and clients when polled is being incorporated within their transitions of care and within their care. So it's vital to make sure that these patients are feeling empowered and feeling incorporated within their care.
So I want to touch on the first transition. So this is the point when a person in the community experiences a painful condition that could require ED care. This transition includes their communities of support and all the facets of community care that precede or preclude ED visits or prepare for them. And the core message from us is that these patients are at very high risk when accessing ED care, and anything you can do to smooth that process is extremely valuable in and out of the ED. So in our case, the person has approached their trusted community providers due to their past experiences in ED care and with their provider, and in the face of the significant risk they face when transitioning into and receiving acute care. And of course, already this patient is doing things to support themselves through their own pain experiences. They're doing their own self-management of their painful condition, which for many people might include self-management with street or prescription opioids or other analgesics that they're able to access. They also might at this point be leaning on peer support through their own networks or through formal peer support. And there's a few things that community providers can do to help them. And we hope to hear from many of you for your strategies during the Q&A. So from our end is things like medication. So clarifying doses in advance of a visit of things like benzodiazepines or opioids that might be high risk during transition, and providing paperwork to that patient to bring with them to their ED visit, especially for people on safer supply, although this is no guarantee of good care due to that heterogeneity we mentioned earlier. Another piece is ensuring pickup and continuity for safer supply dosing to tide them through the waiting period at the ED. And Katie actually, hopefully later we'll have time for her to share a great example of how her provider worked with her to smooth an outpatient elective surgery experience for her. And of course, notifying their pharmacy that they're visiting the hospital so that you mitigate any risk of dose reductions or punitive responses. And then setting expectations and discussing expectations. So things they can expect, risks they might face, wait times, supports available in your setting and the EDs they may be visiting, things like peers, elders, et cetera. And then the provider communication, if you have the opportunity or have contacts within the EDs, so just giving a heads up, it can really do some effort to smooth things on their behalf. And then, of course, developing networks of ED or inpatient champions who can advocate for your patients when they might be outside of your usual sphere of influence. And then more broadly, especially for those of you in leadership positions, advocating for implementation of supportive policy for these patients. And then, that last point, which I've underlined here, is creating workarounds and outpatient pathways, which I'm sure many of you have so much experience with, for patients who decline to visit the ED, because that sadly we've created a situation in which that's often the case. I wanted to highlight, there was a really cool stat that highlights, I think, the importance of primary care. And it was for people visiting the ED with a non-fatal opioid overdose. Assessment by a family physician in the preceding 12 months was associated with a lower risk of opioid-related and all-cause mortality with a hazard ratio of 0.58. So mesh in primary care is so important for these people. So to continue our case, our patient's nurse practitioner and family physician recommend that they visit the ED. They're nervous after the previous experiences there, and they're a bit reluctant to go. But then a friend offers to accompany them, so they go to the ED and are driven by a caseworker from a local community organization. They arrive initially in the ED accompanied by their friend. They come in with a document from their community providers illustrating the slow release oral morphine dosing that they're on and their medical history, and they start the wait in the waiting room. They register, and they're triaged as a CTAS 3, which is sort of a middle acuity. And their triage note says polysubstance use, burned to arm yesterday, because they weren't comfortable to take off their shirt, and no one asked. They missed their dose of Cadian this morning and were self-managing their pain with fentanyl. So now they're in early withdrawal, which increases their already significant pain and discomfort. They're given Tylenol and they're sent to a chair in the busy waiting room. So now that they arrive in the ED, they carry the baseline burden of pain and the strengths of people with opioid tolerance, experience painful conditions we've discussed, and now encountering challenges accessing ED care. But now that they're in the ED, there's actually a few things we can do to improve their pain. And a foundation of empathy and communication can go a long way. And there's a few simple things we can do to improve care and overcome the significant deficit of psychological safety people have during painful experiences in acute care. Things like validating pain experiences, simply stating things like, I can see you're in a lot of pain. Emphasizing our shared goal to treat their pain and to let us know if they're experiencing symptoms of pain or withdrawal. Discussing options for pain management and the plan. Importantly, asking about explaining reasons for asking about things like meds, opiate agonist therapy, or their needs, or for blood work. Blood work piece is especially important because people may have experienced stigma related to blood draws, including privacy and bloodborne illnesses. And then working with people as their own experts in their pain experience and empowering them and making sure that they feel comfortable to share their insight and that insight is valued.
So creating these psychologically safe spaces for patients, and any patients, actually a safety intervention that the Institute of Safe Medical Practices, or ISMP, published this. So medical invalidation, where healthcare providers dismiss, minimize, or otherwise do not take patient concerns seriously, can lead to feelings of distrust and reluctance of patients to seek care. So these acknowledging this power imbalance inherent to the relationship with patients is integral for creating a safe, inclusive, and open atmosphere. And when an incident does occur and there needs to be a disclosure, respond with empathy and allow for a safe space for questions. And this is for all patients.
The next thing we wanted to touch on was policy. So policy for good care in the ED is crucial and the catalyst for uniform care and provider buy-in. This might include things like institution-wide philosophies of care, good harm reduction care in the ED, safer supply policy, and policies on self-administered use in hospital spaces or supervised consumption sites within inpatient settings. And really good policies can provide patient and provider comfort as well, and ensure continuity between different sites of care as people navigate these transitions. And it really helps if patients know that they can expect a certain standard of care, whether they're in the ED, on the floor, in the ICU, or anywhere else. We also wanted to touch on peer support. This is an extremely important component of care that has been mentioned a few times today. There's a bounty of qualitative literature describing the ways in which peer support is valued by people who use drugs, as well as providers. And having someone with lived experience accompany through the ED experience can mitigate much of the suffering that people commonly experience there.
So at this transition of care, more than 40% of medication errors are believed to result from inadequate reconciliation, and 20% of these medication errors result in harm. So some things that we can improve on is, standardization, using correct terminology and consistent orders or notes, effective medication reconciliation, as discussed by the previous slide. And by performing medication reconciliation, the patient needs to be empowered to advocate for themselves. We sometimes get caught up in having these health information systems, either being like a prescription drug monitoring program, drug information system, PharmaNet, where we rely on that. However, these systems can have gaps that are not being covered within these systems. So for example, hospitalization, incarceration, living out of province or country would not be reflected in these drug information systems. So again, it is important to engage the patient to complete a best possible medication history. And you know what? This is a great opportunity to connect with the community resources, such as their community pharmacy, their primary care provider, to let them know that they are in ED. For example, for someone who is on opioid agonist therapy and receives a daily witness ingestion, having communication from the ED saying, hey, the patient is in ED, can I confirm their last dose? And communicate that we're going to dose them in the ED, as well as instructions to, call or leave a message if the patient's discharged, is really important to prevent the potential labeled or miscommunication of missed doses in the community. So again, involving the patient and asking where they receive their medications from is integral to this process.
So now we want to switch tacks and talk a little bit about the ED treatment of withdrawal and of pain. And in this population, in the context of the toxic drug supply, we're talking about two life-threatening medical emergencies. But we really want to highlight that medical management of withdrawal and pain are two different things. So we treat the withdrawal sink, and then we provide multimodal analgesia. If we replace their opiate agonist therapy on its own, we will not be treating their pain. If we provide multimodal non-opioid analgesia, we will not be treating withdrawal. And there's this classic EM myth that's always bandied about in our emergency departments and is instilled in some of our textbooks, which is that withdrawal is not life-threatening. This is wrong in the context of a toxic drug supply. So I wanted to highlight this handy BCCSU algorithm for the management of withdrawal for patients accessing the ED. So basically, for patients on opiate agonist therapy, we work with our pharmacy to continue their baseline opiate agonist therapy. But if they're not on opiate agonist therapy, this is kind of our branch decision-making tree here. So either one, if they are interested in starting an opiate agonist therapy based on their own preferences and what's available in our institution, things like buprenorphine, methadone, or Cadian, we would temporize with non-opioid symptom management, like clonidine, antiemetics, those sorts of things, and then initiate OAT as soon as possible. If they're not interested, then the first line treatment for withdrawal is opioids, immediate release opioids. And I want to make an emphasis that withdrawal management alone is no longer guideline supported, like e.g. the abstinence with just symptom management, and is associated with pretty significant harm, and that IR opioids can be provided safely and legally for the purpose of pain and withdrawal in this population. And I wanted to emphasize here that it's important that opiate agonist therapy is continued during acute care stays and painful experiences. There are so few scenarios, if any at all, where it should be discontinued during acute care stays. There's a ton of evidence, including large systematic reviews from the perioperative and acute care literature, that recommends continuing OAT, and that discontinuation is associated with increased mortality. So really something we try to avoid. So for our case, triage had flagged this person's Cadian dosing for pharmacy, and the ED pharmacist was engaged early. That would be Alex in our setting. And they received their usual dose of Cadian. But of course, they're still waiting to see their physician, and they're still in a lot of pain. So how do we manage that pain? So due to the factors mentioned before, this patient is at very high risk of undertreated severe pain. It requires a deep toolbox of non-pharmacological, opioid, and non-opioid multimodal analgesic strategies. We start with just simple environmental stuff, the non-pharmacologic things, addressing pain with things like ensuring an appropriate setting. For example, severe pain may require more high acuity area of the emergency department. We try to maintain a calm environment if at all possible with appropriate lighting and minimal disruptions. We trust, we communicate, we validate, like we were talking about before. And then, of course, the physical aspects. We try to treat their physical condition and etiology of their pain directly. Things like positioning, elevation of the affected limb, casting and reduction, abscess drainage, and then also non-withdrawal symptom management in addition. So things like nausea and diarrhea that, again, were not caused by withdrawal, because the treatment for that would be opioids if it was withdrawal related. And then, of course, the key backbone of any multimodal pain strategy, a smoke and a sandwich. These can be extremely helpful and are often available in emergency departments. Other things, a basal NSAID and acetaminophen backbone, if clinically appropriate, can provide a ton of analgesic effect in these patients. Something we also use in our setting quite commonly now is analgesic dose ketamine. It's been shown in multiple systematic reviews to be as effective in reducing pain scores as IV morphine and stacking an effect. And it can be given IV, it can be given intranasally, it can be given nebulized. It's a good, safe option for patients who wish to avoid opioids or as a multimodal adjunct. The one thing we caution is just be careful of the dosing, because this is a very dysphoria intolerant population. And so we use sort of the lower end of the analgesic dosing. Gabapentinoids, we do not give them, and we recommend avoiding them. There was a meta-analysis recently of 281 randomized controlled trials. And the current evidence is that there's no meaningful difference in acute, subacute, or chronic pain with the use of gabapentinoids. So we are not giving that. What about opioids for acute pain in this population? Not all will need opioids, but for those who do, they will need more. And the central concept here is work with people as their own decision makers. And then in the context of highly tolerant patients, start with safe dosing and then rapidly up titrate with frequent assessments and monitoring. The doses that we're giving in the merge might be much higher than many ED providers are used to, and the community providers are often much more comfortable with this than the ED providers. A little bit of myth busting around this in the ED is that there's no evidence that time-limited use is associated, in acute pain is associated with the risk of relapse, but there is demonstrated harm for overdose mortality in the context of undertreated pain. And also that ED contributions to the opioid crisis were in prolonged prescriptions of outpatient opioids to naive patients, not the treatment of acute pain for people with existing tolerance. A totally different population. And I think there's still a lot of residual fears about that in the ED population. Another frustrating one is that there's no safe, validated way to estimate baseline tolerance. And I defer to all of your clinical expertise on that. But the central goal is, if you have you're the worrywart type, is just start in a safe dosing range, but then keep at it and rapidly up titrate up. It's quite safe to do so. Communication pieces, ask their preferences. Some people might wish to avoid opioids entirely. Some people might wish to avoid IV. Some people might wish to avoid PO. All of these may be appropriate. And communication is so key during that up titration phase. So saying things like, this sounds like really bad pain. I'm sorry you're experiencing this. Our goal is to treat it. If your pain is still bad, let us know and we're going to raise your dose. And then frequently checking on them and up titrating, which again can be challenging in the busy ED setting. Another thing that we found very helpful is a pre-brief with the nursing team or whoever's administering the medications, saying things like, this person is very opioid tolerant and will likely need extremely high doses, and then enlist their expertise for monitoring for things like under analgesia and over sedation. I included some dosing ranges here, which are almost guaranteed to be underdosing significantly. But I just wanted to say, like, that you can start safe. You give your 10 milligrams of IV morphine, and then you, every 10 minutes, once it's taken max effect, bump it up. Get them under control with IV, and then transition to PO for sustainable dosing. You can use morphine, you can use hydromorph or fentanyl. And fentanyl can be particularly useful when high affinity agonism is on board, like e.g. For patients who are on buprenorphine, or in the context of just severe pain that you need to get under control rapidly. But some people require massive doses. We're used to giving 50 or 100 micrograms of fentanyl in like a trauma situation, for example. But some people, of course, are requiring doses of like 500 to 1500 to even begin to touch their pain. It might be even higher. And again, the key here is frequent up titration. And what about for patients who are on buprenorphine or methadone or Kadian or other agonists? And the key thing here is that mu agonists, so those opioids we're just recommending, work for patients on all of these. They work for patients on buprenorphine. You might just need really, really high doses as they occupy those remaining receptors. And so again, same fundamental principle that we use is starting in normal ranges and then just working with your nursing team and with the patient to rapidly up titrate in a safe way. So returning to our case, so our patient has now been assessed by their physician. They had a very painful dressing change for their burn, as well as ongoing pain from the burn itself. Their physician noted and then provided them with some basal NSAIDs and acetaminophen. They provided them with an IV ketamine bolus, as well as IV hydromorphone, which they rapidly up titrated to effect over the next hour with frequent communication. Then our patient is consulted to the plastic surgery service for further management. During the time that they're waiting to be assessed by the consultant team, their friend received a rude comment from a security guard and the friend left. So now the pain is ongoing, but they're now alone. The plastic surgeon sees them a few hours later and is uncertain about the rules administering these now high doses of hydromorphone because the busy ED providers haven't communicated the rationale for these doses to them, sadly. And then even more sadly, the consultant is mistrustful when the patient tells them what works for them and what happened. So the plastic surgeon was a little worried and they decided to consult the addictions team, but now it's overnight and the team isn't available until tomorrow. So now the patient is waiting in a noisy, bright emergency department, unsure of what comes next. We wanted to touch on how admission from the ED to inpatient is a really dangerous transition. And we mainly highlight this to highlight the role, especially for those of you in decision-making capacities. It's important to have institution and system-wide policy to support homogeneity across different settings, floors, emergency departments, ICU, et cetera, to ensure a safe transition when getting admitted and moving between care settings. So now we continue our case. Our patient has been waiting overnight in the emerge for their admission in severe pain. It's been a few hours since they've seen any physician or received any doses of analgesia. They feel forgotten. They feel unheard and invalidated after the episode of mistrust with the surgery team, despite voicing their ongoing pain and need for additional pain management. They leave and they treat their pain and withdrawal with street fentanyl upon departure. So we want to talk about safe discharge because discharge is the final and riskiest transition. It's an extremely high risk time for overdose, extremely high risk time for mortality, and it can also be the final moment any healthcare provider sees this person alive. The risk of discharge include risk of overdose following discharge. In the first 6 days, there's an incident ratio of about 6.92 for overdose. There's barriers to continuity with things like pharmacy or community providers or outpatient medical follow-up. There's a lack of connectivity and communication between providers and the patient in terms of functional phone numbers, addresses, or ways to communicate post-discharge instructions and follow-up to patients. And then, of course, there's bad experiences that result from discharges that may result in future care avoidances and death. And people may be discharged by care providers, or it's very common for people with undertreated pain or withdrawal to discharge themselves. So substance use itself is a risk factor for departure before medically advised, and the reasons are multifactorial. And we use the term before medically advised because it frames it in a bit more of a person-centered way than against medical advice, and it reflects all the factors, including undertreatment, including stigma, that may drive a person out of the hospital, which has very little to do with a person being against any medical advice, and much more to do with the neglect and inappropriate care that we can provide in patient settings. Early hospital departures have been evaluated in a systematic review, which identified a prevalence of around 30% of self-discharge from hospital amongst people who use drugs, with higher rates for Indigenous people and people who inject drugs. There was a study by Jessica Moe in BC, one of the emergency physicians out there, that found that people who left before medically advised in the context of an ED, there is a far greater risk of mortality than those who did not leave before medically advised, and an increased risk of overdose generally. There was a great qualitative paper as well, published in 2020, that identified the 4 key issues that contribute to people's reasons for leaving the hospital prematurely. 1, undertreated withdrawal. 2, uncontrolled acute and chronic pain. 3, stigma and discrimination by hospital staff about their substance use disorder. And then hospital restrictions, including not be allowed to intermittently leave the hospital floor. This is the stuff we're trying to mitigate with this talk.
So with transitions of care, and for those that do leave the ED, providers have a key safety role. So treating pain and withdrawal, prescribe a short course of outpatient opioids. And if we are, starting OAT in the emerge, community referral and community follow-up is the most important piece for that continuity. Standardization and discharge planning is making sure that there's timely communication of, discharge summaries and prescriptions that are available once they leave the ED. Providing our patients and clients with harm reduction supplies such as take-home naloxone kits, and we in Nova Scotia we have these brown bag programs, so actual clean supplies before they leave. Education and supporting the patients, provide clear, accessible patient education with return to emergency department instructions, as well as engaging our supports such as peers, friends, social work, housing supports in this transition. Ensuring, a warm handover to community providers, which include pharmacy, and ensure that referrals are put in a timely manner, as well as appropriate coverage. We have to just prescribe things and not take into account how accessible this is to the patient. So is it a pharmacare benefit? Can the patient afford it? Are we prescribing it properly on, a triplicate pad? All these things need to be taken into consideration.
So now to wrap up our case, our patient's now back in the community. They visit their nurse practitioner and their family physician again at the clinic they have trust with. They're now in the waiting room and they're drowsy. The family physician reassesses them and then calls a plastic surgeon that they know to be a champion for this community, who offers to see them in clinic. In the meantime, their family physician provides and nurse practitioner provide breakthrough pain medications in the form of oral hydromorphone, Tylenol, and Advil in coordination with their community pharmacist, in addition to some Vaseline and some dressing changes. They end up not needing to go back to emerge, and they follow up with plastic surgery as an outpatient. So, in summary, we should trust our patients with their pain experience. Their pain is real. Their pain is dangerous. Transitions in acute care are really high risk situations, and community providers can help so much in improving people's pain experiences before, during, and after their acute care stays. We just want to thank you all as well for the great community care that you provide to mitigate some of the risks that people face when accessing care in the ED. And on a daily basis, we in the ED notice your hard work and do appreciate it. So thank you so much. We have here just a reference slide. There's a QR code here. Katie and Alex and I are going to stick around to answer some questions. And we'd also love to hear about some of the strategies you use in your own practice to provide care from this population. For those of you who want to get our contact info, if you scan this QR code, our emails are in there. There's a download link for all the references as well. So thank you so much for listening. Maybe we'll give a few seconds for some questions to roll in, and if none pop through, Katie, maybe you can share that experiences that you mentioned with the acute care.
Yeah, it looks like someone's typing in the chat, so fingers are going at her.
I'll just jump right in there while people are thinking, if that's okay. Yeah, there's an experience I had recently that I thought could be relevant to this talk. I had mentioned that I transitioned off of Safer Supply. It was back in December of 2023. And I did transition onto methadone because my goal is to be abstinent from opiates. But I was lucky enough to actually keep my Safer Supply doctor, and he prescribed me methadone. So his philosophies around how to care for me were a lot different than the clinics I had experienced. But anyway, I needed 2 day surgeries at the hospital, and I'd had this particular procedure before. I found it really painful, and all of a sudden I've been tapering on methadone. So I was on about 10 milligrams of methadone in February and March, and I was terrified because to be in withdrawal and then, it's hard to get through my day-to-day and then have that procedure, but it was an important one and preventative. And I would rather not go than not know that I'll have opiates to treat it. And so I had a conversation. I wish it could have been with my primary care provider, but I didn't feel that he would be receptive to this. So I had a conversation with the doctor who had been treating me with Safer Supply and then methadone. I asked him for Dilaudid for a short-term prescription to have with me so that I knew before I went that I could treat my pain and I wouldn't have to go to the street. And, we had a lot of discussion around it. I knew that I would inject it because I just can't seem to take them by mouth, but I really did feel that I could inject a 2-day supply and then go back to my 10 milligrams of methadone. And that would make me feel comfortable to have these day surgeries. And he agreed. And I really feel that there was 2 things going on there. Of course, fear of withdrawal, fear of pain. I must say I didn't actually get any, they didn't offer me any pain care. They just put me under with the gas. And knowing that I had that prescription, I took some even before I went. So I was comfortable arriving. So, and I also think part of it was a fear of the hospital. All these terrible experiences I've had, I wanted to be numb to enter that facility. And I think that's really real. And he trusted me that I could handle that. And I did it twice because I had 2 surgeries in February and March. And I'm down now to 5 milligrams of methadone. I was able to stick with my goal. And so I just thought that was a really successful way if we're not sure that patients are going to get the pain care they need in hospital, to find these workarounds. So I just thought that might be a helpful story to share. It made my experience so much better. But I even remember when I woke up from the surgery, I was wide awake. Like sedatives, drugs don't really affect me. And I remember the nurse coming in and she started dressing me. And I was like, no, like she wasn't used to people being so alert, right? Like I wasn't sedated at all when I came to, and I was like, why are you dressing me? Like, so it just was really clear to me that, I don't think that they were used to treating someone that had a tolerance like I did to those kind of sedative medications. So that's all I wanted to share.
Awesome. Thanks, Katie. How are you? You sending us off?
I think so, yes. Louis, Alex, and Katie, thank you so much for this fabulous presentation. It was awesome. Thank you to the 3 of you again. This was fantastic, and I hope everyone enjoys the remainder of the day today.